First, we have Dr. Bridget Ollesch. So as I mentioned, she's one of our second-year movement disorders fellows here at the University of Colorado. She is from Central Illinois and received her undergraduate degree in religious studies at Mount Vernon in Iowa. She then completed medical school at Southern Illinois University in Springfield and her residency at the University of Utah in Salt Lake City. She's currently completing the advanced therapies program within her movement disorders fellowship. And that means things like deep brain stimulation and focused ultrasound. And she was also awarded pilot funding to study gender disparities in sleep research. Sorry, I talk about sleep all the time. And deep brain stimulation. My apologies. All right, so everyone welcome Dr. Ollesch.
Morning, everyone. Thanks for coming out. So I'll be talking about medication updates. I don't have any disclosures. So goals for this are to do a little bit of a brief history and discussion about levodopa, which is kind of the mainstay of therapy, how there are different levodopa formulations and how they work, and discuss different medication classes and some newer medications within those classes to help for the treatment of Parkinson's disease. So Dr. James Parkinson first described Parkinson's disease in 1817 when he published his essay on the shaking palsy. And then in the 1960s, it was discovered that dopamine was depleted in Parkinson's disease and that levodopa, which is a precursor to dopamine, could help improve symptoms. So Parkinson's disease, some of you may already know this, but this is caused by a loss of brain cells that produce the neurotransmitter dopamine. Loss of dopamine then results in the symptoms of Parkinson's disease, with some of the main ones being a resting tremor, rigidity or stiffness, and bradykinesia or slowness of movement. So levodopa is really our mainstay of therapy. So most commonly, we're going to probably talk or start with carbidopa-levodopa. The brand name of that is called Sinemet. And sen means without, met means emesis. And so essentially, you have levodopa, which is the precursor to dopamine, but you also have carbidopa, and this prevents the breakdown of levodopa in the gut before it reaches the brain to try to help with nausea. There are several side effects, some of the most common being GI upset, like that nausea or vomiting. A lot of times that can improve over time though, and we usually start at low doses and increase slowly to try to help with that. Dizziness, lightheadedness, drops in blood pressure, hallucinations, although this is going to be typically more in advanced Parkinson's disease. And it can also cause dyskinesias or those extra wiggly movements. One example is Michael J. Fox, if you've seen him. And this is more related to the consequence of how long you've had Parkinson's disease and the amount that you're taking. So there are several levodopa misconceptions that I wanted to just get out of the way here. So so levodopa is toxic and hastens disease progression. That's not true. Levodopa loses its efficacy over time. That's also not true. Levodopa leads to earlier dyskinesias. That's also not true. So there was one study that compared a large cohort of patients with Parkinson's disease in a sub-Saharan African country, Ghana, where access to medication is limited, and the initiation of levodopa therapy often occurred many years after the onset, and they compared this patient population to a population in Italy where levodopa was more readily available and often started earlier. They basically found that motor fluctuations and dyskinesias were not associated with the duration of levodopa therapy, but rather with longer disease duration and a higher levodopa dose. Therefore, there's no benefit or reason to delay the start of levodopa therapy. And I think this helps illustrate this. Hopefully this is helpful. So as you can see, this is looking at the therapeutic window. And when you're in the mild stage, it's really easy. So those peaks are where the medication peaks up and then it falls down. And you can see that in the mild stage, it's pretty easy to stay in that therapeutic window. As the Parkinson's progresses and becomes more severe, that's when you start to see that it's harder or more difficult to stay within that therapeutic window. And that's when you start to see those dyskinesias or more of that off time where you're having worsening of your Parkinson symptoms. There are several different formulations of levodopa. There's the immediate release. This is commonly the first one that we start with. On this graph here, it's the light blue one. It has a quick peak of dose, and it's generally dosed at least 3 times per day. There's the controlled release, and on this one, that's the red peak. So it has a slower onset and a lower peak. And there's also the extended release. So this is a combination of the immediate release and the extended release. And on this graph, it's the darker blue. And the one that you'll hear about is Rytary. So this is an overview of the different medications that we'll get into here. So we'll talk about each of these, but this is just kind of an overview slide. And then, so there are different formulations of carbidopa-levodopa. I believe there was one question already sent kind of beforehand asking about Cinemet and protein. So if you are eating a lot of protein or protein-heavy meals, it can interfere with the absorption of this medication. So we typically do recommend trying to time it at least 30 minutes before a meal. So one thought is, when you start thinking about making dinner, go ahead and take your medication, then make dinner, and then by the time it's ready, that's kind of probably at least 30 minutes beforehand. Sorry. So this is basically, this is carbidopa-levodopa. The only difference is that it has scoring, so it's a little bit easier to break. Unfortunately, it's only a brand name right now, which is Divi, so it can be a little bit on the pricier side. This is a medication, Crexont, or IPX203. This is another version of extended release carbidopa-levodopa. This was approved pretty recently in August 2024. Trials showed improvement in daily on time compared to the immediate release, and it was dosed an average of 3 times per day compared to 5 times per day for the immediate release carbidopa-levodopa. This was not compared directly to Rytary, though. Sorry, go ahead. What did you want a picture? Okay. In Bridget, this is inhaled levodopa. So this can be used as kind of a rescue medication taken on an as-needed basis. So anytime you're having sudden off periods or you're having a failed dose of your medication, this is not meant to replace your other medications, though. The side effects are pretty similar to levodopa. However, because it's an inhaled formulation, you can also get cough or upper respiratory infections or change in saliva color. There is Duopa, which is an intestinal gel. This was approved in 2015 by the FDA. This essentially gives carbidopa-levodopa directly into the GI system to try to keep the levels a little bit more constant instead of having the peak when you take a medication in that fall. So it can be helpful for patients with motor fluctuations or having those unpredictable on or off times. And compared to oral tablets, studies have found that you can get 2 more hours of on time without bothersome dyskinesias. Subcutaneous pumps. These are not currently FDA approved, but they are waiting for approval and, probably pretty close to seeing approval for these. Essentially, this is, you'll get delivery of medication through the skin at a regular rate. And their side effects can include site reactions, such as redness, irritation, or skin infections. And these have been shown to have increased on time without troublesome dyskinesias. There are 3 different ones that are currently waiting for FDA approval at this time. Dopamine agonists is another class of medications that we sometimes use. So pramipexole or Mirapex, ropinirole or Requip, rotigotine or the Nupro patch, and in some cases apomorphine, which is the Apokin injection pen, which I have a picture of down there. So some advantages to this is that there are different formulations. They may be less likely to cause dyskinesias, less of an interference with protein, and they do have long-acting versions. However, these medications do have a lot of side effects, including leg swelling, sleepiness or sleep attacks, low blood pressure, impulse control disorder. People might have a harder time controlling impulses, which could lead to hypersexuality or excessive shopping or gambling that they weren't doing before. Punding, which is kind of people doing repetitive, meaningless tasks, like organizing, reorganizing their jewelry, for example. And then, yes, I already mentioned that this is a picture of the Apokin pen. So this can also be used as a rescue medication for abrupt off periods. An agonist means that it works on the dopamine receptors. That's what that means. Yeah. So there are also NMDA receptor antagonists. The main one that we use is amantadine. This can be used to treat Parkinson's disease symptoms, but more commonly we use it to treat dyskinesias. Regular amantadine is typically taken 2 to 3 times per day. There is a long-acting formulation that can be taken once per day. It is also available in a liquid formulation. And you want to be sure that the dose of this often has to be changed if you have kidney problems. You want to make sure that your prescriber is aware of that. Side effects can include insomnia, nausea, dizziness, confusion, dry mouth, constipation, falls, and livedo reticularis, which is that rash that's seen on the legs there. Amantadine ER is also called Gocovri. This was the FDA approved in 2018 for levodopa-induced dyskinesias, and in 2021 for off symptoms of Parkinson's disease. This is taken once daily at bedtime. The side effects are very similar to regular amantadine. This is just a once daily formulation. Another class of medications that we use are called COMT inhibitors. Essentially what these do is they stop an enzyme that breaks down dopamine so that more levodopa sticks around longer. So this can add more on time per dose. This is taken with levodopa. It does not work by itself. There are several different ones there that I've outlined. So there's entacapone, the brand name Comtan. This is taken with each dose of levodopa. There's tolcapone or Tasmar. This is a 3 times a day. Opicapone or Ongentys is a once daily. Side effects can include GI upset or the change in the color of the urine. And specifically with tolcapone, there can be liver damage. MAO inhibitors, these block an enzyme in the brain that breaks down dopamine, allowing it to function longer. This medication can be used alone or with levodopa to increase on time. Side effects can include flu-like symptoms, elevated blood pressure, or insomnia. Sometimes we use selegiline to help with fatigue because it can cause kind of increased energy. There's several different ones: rasagiline, selegiline, or sulfonamide. And rasagiline and sulfonamide are once daily, while selegiline is twice daily. Another medication is called istradefylline. The brand name of this is Neurans. This is used on top of other Parkinson's disease medications. It's not used on its own, and this is to try to help treat off time. This can worsen dyskinesia. The precise reason it works is not entirely known, but it is an antagonist, so it works against the adenosine A2A receptors. This caffeine actually also acts on the same receptor. In patients with Parkinson's disease, dopamine levels are decreased, and this reduces the activity of the GO pathway and increases the activity of the no-GO pathway. So as Parkinson's disease progresses, the adenosine A2A receptor concentration increases, and the effect of adenosine on the no-GO pathway becomes more prominent. So this medication is thought to work sort of by preventing the breaks. There's a couple other drugs in the pipeline that I thought might be useful to mention. So P2B001 is a low-dose extended-release formulation of pramipexole and rasagiline. This is in development for the treatment of motor symptoms. Tavapadon. This drug aims to target and activate certain dopamine receptors to improve Parkinson's disease motor symptoms while attempting to minimize side effects. And the thought behind this is that it selectively targets D1, D5 receptors instead of D2, D3 receptors, which are typically targeted with the current dopamine agonists. Thank you so much.